Hey everyone, Nurse Mike here from SimpleNursing.com. Today we're breaking down renal failure, chronic kidney disease, and end-stage renal disease into simple, high-yield concepts tailored for your nursing exams. So get ready for visual cues and memory tricks to make it all stick. And if you're a Simple Nursing member, be sure to grab these 3 study guides to follow along. All right, let's get started. Now for renal failure, we're covering acute versus chronic. So for chronic kidney failure, also called chronic kidney disease, or just CKD, this is long-term chronic damage to the kidneys. We're talking over years and years of destruction, typically resulting in permanent damage. And acute kidney failure, also called acute kidney injury, is that sudden, short-term loss of kidney function, but if not stopped or reversed, it can lead to chronic renal failure. So a Kaplan question asks about acute kidney injury. What is the correct understanding? And the answer is sudden loss of kidney function due to loss of renal system circulation or glomerular or tubular damage. So what's really going on in the body? For pathophysiology and causes, let's cover the acute kidney failure first. In acute kidney failure, it can result from 3 types. We have pre-renal, that decreased blood flow to the kidney. So the memory trick we use is think of decreasing of prefusion with pre-renal. And then next is intrarenal, that damage inside the renal. Think in the renal for intrarenal. And if the cause is after the renal, that's post-renal. So just think post for past renal. Now let's dig into the specifics here. So for pre-renal, just think of that decreased perfusion for pre-renal. Oxygen-rich blood flow can't get to the kidneys. This decreased blood flow means decreased oxygen. So remember, oxygen is the money of the body. No money, no honey. No oxygen and the body goes broke and dies. Kind of like the kidney is suffocating to death. Now, this is typically caused by obstruction or vessel occlusion, where we have a blockage of blood flow, which blocks oxygen. Now, this is typically from an emboli or a blood clot or even a tumor that blocks perfusion into the kidneys. Another cause is from low blood pressure, that low perfusion with pre-renal. Like patients with shock, hypovolemia from that major blood loss or volume loss resulting in dehydration, which results in decreased MAP, that mean arterial pressure. Fancy words for low blood pressure, meaning low perfusion, less than 65 MAP, or mean arterial pressure. Lastly, low cardiac output, we get low perfusion. So just think low cardiac output means low oxygen put out of the heart, resulting in low perfusion to the kidneys. Typically from when the heart can't pump correctly, which decreases blood being pumped out of the heart. So we see this with ECG dysrhythmias, with those funky beats, and even clients in heart failure, which is a little bit tricky, so listen close. Even though we may have high blood pressure with heart failure clients, the big problem is low cardiac output. We get low volume of oxygen-rich blood out of the heart. This results in less perfusion and less oxygen to the kidneys. Next, we have intrarenal, that direct damage inside the kidney itself. Again, think intrarenal for inside the renal. Now, this is far more serious because it's more intense with intrarenal. Now, it's also referred to as ATN, acute tubular necrosis. So just think ATN requires immediate attention. Now, typically it's caused from infections resulting from glomerular nephritis or even autoimmune diseases like lupus, where the body attacks itself, resulting in nephrotic syndrome, which we cover both in a separate video. But really the most tested top 2 causes for exams, write these down, is CT contrast dye, like with a heart cath. So just remember, contrast kills the kidneys. And even antibiotics ending in mycin, like vancomycin and gentamicin. So just think it's a sin to give a mycin, since it's so damaging to the kidneys. Lastly, untreated infections and even long-term use of NSAIDs like naproxen, ibuprofen, and even ketorolac can cause damage to the kidneys. It's kind of like overloading 2 delicate washing machines with thick cement, We literally clog the kidneys here with these medications, and in result, the creatinine lab value shoots up sky high. So the key number to know is creatinine over 1.3 is bad kidney. And the memory trick we use, just think of the 3 C's. Creatinine is the most critical lab value since it shows clogging of the kidneys. And last but not least, we have post-renal. Just think past the renals. There's a renal blockage after the kidneys, which basically blocks the outflow of urine, so urine can't get out of the kidney itself, causing a lot of pressure, pain, and strain on the renals. Like with clients with renal calculi, aka those kidney stones, or even a tumor, or even BPH, that benign prostatic hyperplasia. We see a big swollen prostate in our older men populations. So just think the memory trick, BPH, as a big prostate that holds back urine, and now we have an outflow problem. As far as assessment findings, these are pretty simple. So remember from our anatomy video, what are the 3 waste products that the kidneys filter? Well, remember we use our acronym HOOK, H-U-C, since the kidneys sort of kind of look like a pirate hook. H is for hydrogen ions, which are very acidic, U is for urea, and C is for creatinine. So the key numbers to know is creatinine over 1.3 is bad kidney, BUN over 20 is very bad, urine output 30 mLs per hour or less means the kidneys are in distress, and metabolic acidosis is pH below 7.35. This is typically due to the retention of all those hydrogen ions, which pushes the body into an acidotic state. Now, Kaplan had a question about this, asking what is the best indicator for good renal function? And the answer is 1,500 milliliters of urine in 24 hours. Remember here, urine output 30 mLs per hour or less means the kidneys are in distress. So 1,500 is very, very good in 24 hours. Now, this next part is not a big focus on the NCLEX, but it may show up on your nursing exams. The 4 phases of acute renal failure. So number 1 is the onset of injury, known as initiation, which is not typically tested. Step number 2 is the oliguric phase. Now, this one is key to know. So just think of the O's in oliguric as O for low urine output, less than 400 mLs in 24 hours. Remember, urine output 30 mLs per hour or less means the kidneys are in distress. So 400 mLs in 24 hours, wow, that is really, really low. And just think very sticky, thick urine, we get specific gravity that is high. So the memory trick we use is if urine is dry, then the specific gravity is high. Now the third phase is the diurese phase, also called the polyuric phase. So just think diurese, D for draining urine, a dramatically high urine output, like 3 to 6 liters per day. The kidneys are basically trying to flush out the problem. So very low liquidy urine with a specific gravity that is low. The last phase is the recovery phase. So just think R for really slow recovery, since it can take up to 1 year to fully recover. And the key numbers are returning to normal during this phase. Now, a HESI scenario asked, oliguric phase of acute renal failure, some key findings. And the answer is anorexia, nausea, vomiting, and, key term here, decreased urinary output. So just think low urinary output with oliguric phase. Now, the treatments are pretty simple here. The main goal is to prevent major kidney damage. And we do this by flushing the kidneys with a fluid bolus, or diuretics. We're basically trying to push the kidneys from oliguric phase into the diuresis phase. So HESI mentions a patient reports a loss of appetite, severe headache and lethargy, and dry mucous membranes with key terms here. Urinary output 300 mLs in 24 hours, that is really, really low. Elevated blood urea nitrogen, that BUN, and serum creatinine. So the answer is to treat with furosemide. Now, if you didn't know, furosemide is a diuretic that pushes the kidneys into the diuresis phase. So just think furosemide ends in ide, so the body is dried from diuresing all that fluid from the body and into the potty. Be sure to have this study guide handy for this section, so you can follow the content, and make this knowledge actually stick. Now, switching gears to chronic kidney disease. This is a gradual loss of kidney function going in stages, kind of like shirt sizes, going from extra small to extra large problems. Now, we have 5 stages of CKD based on the GFR, the glomerular filtration rate, stating how much blood can be washed by the kidneys in each minute, specifically inside these little washing machine bubbles called the glomerulus. Now, key term, write this down, over 90 mLs per minute is considered normal. As you can see here, as the GFR gets less and less, this means the kidneys are in distress. This means that less and less blood is being washed, resulting in the blood filling up with waste and excess fluid and way too many electrolytes. Now, this is no laughing matter because the kidneys are in distress here. But here's the key point. The 5 stages are not really tested on the NCLEX, but it can be on your nursing exams. So really focus on the stages 4 and 5 here, since it means that the end stage of this renal disease is getting really bad. Here the kidneys are failing, basically failing to filter the blood with this low glomerular filtration rate, that low GFR. So stage 4, we have 29 to 15 GFR, and stage 5, this is the worst, 15 or less GFR. This is considered end-stage renal disease. Now, the kidneys are basically dead in this stage. There's no way to bring the kidneys back to life, so we typically have to do a kidney transplant and put our patients on dialysis in the meantime. Now, dialysis, that machine version of the kidneys that are used to wash the blood, which we covered in a separate video. Now, let's cover the causes of chronic renal failure. The first cause is older age. Geriatrics typically lose 10% of renal function each decade. Technically, older age just leads to physiological decrease of renal function and not renal failure specifically, but you get the idea here. Now, the most tested causes for chronic renal failure is from long-term years and years of chronic damage. So please write this down. You have to know that uncontrolled diabetes from uncontrolled high sugar is a major cause, as well as uncontrolled hypertension from that uncontrolled high blood pressure, and even unchecked autoimmune diseases where the body attacks the kidney. So to help you paint the picture better here, just think of a patient with diabetes who has uncontrolled hyperglycemia for years. Just think of all this thick, syrupy blood like sugary maple syrup being poured into the body. It's like mud inside the delicate kidneys, specifically inside the delicate glomeruli. What do you think it's going to do to the kidneys here? Do you think it's going to destroy them? Well, yes, it's like thick cement being poured into a delicate washing machine, which eventually kills the kidneys, resulting in renal failure. Or what about a patient with years and years of uncontrolled high blood pressure? Think about all that pressure coming from the heart and just pounding against these poor little blood vessels inside the kidneys, eventually scarring and hardening those glomeruli, leading to less blood flow and resulting in kidney failure. That's why it's so important to educate your clients to control their sugar and high blood pressure. Lastly, other main causes include infection causing glomerular nephritis, acute renal failure that worsens and progresses into chronic kidney disease, and even polycystic kidney disease, where cysts develop inside the kidneys themselves. Hesse mentioned this, asking about polycystic kidney disease, indicating that the client is at risk for end-stage renal disease. Now, whatever the cause, the diagnostics are typically the same here. So, creatinine, our number one kidney lab, remember, over 1.3 means bad kidney. Again, think of the C's. C for creatinine, C for critical lab value. So a key term to know is creatinine clearance test. This measures how much creatinine waste is being cleared from the body and into the potty. Specifically, how well the glomerular filtration rate is working to wash the waste out of the blood. The test requires both a urine specimen and a blood specimen in 24 hours. So the key points to write down and to know for your exams is 24-hour collection of all urine in a container.
and we put it on ice to keep it cold. And another key point is you discard the first urine specimen when the test begins. Write that down. It's always a test question. Now, don't let the NCLEX trick you here. We do not need a midstream sample or a sterile container. That's mostly used for UTIs when you're checking for bacteria or infection. Now, a HESI question asks, what's the correct understanding of creatinine clearance test? And the answer is to save all the urine samples in a container for a designated period after discarding the first urine. So you kind of see how those two key points are tied in there.
Unlock thousands of questions and exit prep lectures in our membership, your shortcut to boosting your path to nursing success.
Now, switching gears to signs and symptoms, just think about the patho here. You have broken washer machines, right? So we can't wash the blood from waste or excess electrolytes and even fluid. But most importantly, we can't get fluid out of the body and into the body. This lack of urine output is called oliguria. So remember the O's for low urine output in oliguria. Very, very low urinary output, like less than 400 mLs per day. So Kaplan mentions a patient with chronic kidney disease, oliguria is expected for low urinary output. Another highly tested area is the critical complications. So just think all this excess fluid and electrolytes are trapped inside the body and can cause dangerously high blood pressure from all that fluid volume overload. Now, dangerously high blood pressure can lead to strokes, heart attacks, and even further kidney damage from that high tension on all the organs. So the first priority is to monitor for hypertensive crisis. Now, the priority key signs to write down. Huge NCLEX tip here. So number 1 is headache. Number 2 is nausea and vomiting. And number 3, a really big one here, is change in mental status. Now, these 3 are always priority, requiring immediate assessment. Write these down. We saw them on various question banks. For key term, hypertension crisis. You must report these key signs to the HCP provider immediately. Now, clients can also get multiple other signs revolving around fluid volume overload, including crackles in the lungs, those wet fluid-filled lungs, JVD, that jugular vein distension, as well as bounding pulses from that fluid volume excess. But these do not take priority over hypertension crisis, so you must know that for your exams and ultimately the NCLEX. Another sign is anemia, those low RBCs, red blood cells. Since the kidneys release erythropoietin, which is that hormone that stimulates bone marrow to produce red blood cells, which helps carry oxygen around the body. But typically that's expected to know and not tested. Now, what is tested is excess waste and electrolytes in the blood due to these broken washer machines. So for waste, we have hydrogen ions. Just think acid when you see hydrogen ions. We get metabolic acidosis with a pH below, key number here, 7.35, due to the retention of all those hydrogen ions. And we also see urea, since it can't get out of the body and into the potty, which eventually develops into uremic frost, those crystallized urea deposits on the skin. Basically, white frost causing pruritus, that itchy skin. But again, these are normal and to be expected, and not priority over hypertension crisis. Remember, those headaches, nausea and vomiting, and change in mental status are all priority here, so don't get it twisted. Now for the electrolyte values, these are always exam favorites, so be sure to write these down. Sodium is high, over 145. Just think high sodium, we get high swelling, which can lead to hypertension crisis. Phosphorus is high, over 4.5, which leads to decreases in our calcium, leading to osteoporosis, those porous, weak bones, making a huge risk for fractures. Now, the big critical one here is potassium that is high, over 5.0. Now, this is the most important number 1 electrolyte on the NCLEX and nursing exams since it pumps the heart. So the memory trick we use is the 3 Ps. Just think, P for potassium is P, priority, since it pumps the heart muscles. So with high potassium over 5.0, we get high pumps of the heart, resulting in peak T waves and ST elevations from high pumps. So key terms to know. Peak T waves happens when potassium is 6 to 7 microequivalents per liter. ST elevation happens when potassium is between 7 to 8. And wide QRS complexes is a late sign, over 8. Basically, the heart is cramping up from too much potassium. Too much high pumps makes a very tight heart that is just basically cramping all up. You have to think that the heart's a muscle, right? So, do you really think the heart can pump normal if this muscle is cramping? Well, no. So this leads to bradycardia, that low heart rate, since the heart is too tight and can't beat correctly, and which ultimately results in weakness, fatigue, and lethargy from less cardiac output, meaning less oxygen out of the heart into the body. And then finally leading to deadly ventricular dysrhythmias like VTach and VFib, that ventricular tachycardia and ventricular fibrillation. If not treated immediately, this will cause death by cardiac arrest, basically that stopped heart. So that's why potassium is priority on the NCLEX and nursing exams, since it pumps those heart muscles. Now, Kaplan had a scenario asking, a client with kidney disease is very weak, lethargic, and bradycardic, asking for a suspected finding for this patient. So the key term here is kidney disease, that is weak, lethargic, and bradycardic, that low heart rate. So you have to automatically prioritize and think about potassium here. So potassium 8.5 is the lab value to be suspected. Now, in terms of treatments, the long-term solution is to wash the blood with dialysis, but this can take some time to set up. So the immediate priority solution and treatment is to lower the potassium and protect the heart from deadly dysrhythmias. We do this with drugs in a very specific order. So write this down for priority treatment. Number 1 is IV calcium gluconate. For the key term, write this down, dysrhythmias. Just think gluconates helps to glue down those crazy heart muscles, preventing deadly dysrhythmias, like wide QRS complexes, which will eventually progress into deadly VTach and VFib. We must glue down those heart muscles with calcium gluconate. Now, if the key term of dysrhythmias is not involved in the question, then we progress to number 2, which is IV 50% dextrose and regular insulin. This helps to lower the potassium. So just think, insulin puts sugar and potassium into the cell, out of the blood and into the cell, which lowers blood serum potassium. Most effective way to lower blood potassium very quickly. But insulin also lowers blood glucose too, basically that blood sugar. So that's why we also give dextrose to help prevent that low blood sugar, that hypoglycemia. Now, don't let the NCLEX trick you here. What if the key term dysrhythmias is not in the question? Well, then we progress to option 2, which is just to give the IV dextrose and insulin first to lower that high potassium. And lastly, 3 and 4, we can also give K-exolate, that polystyrene sulfonate, as well as dialysis. But again, these typically take longer to lower potassium, so that's why we put them last here on the list, because they take a longer time.
Let's review some of the most commonly missed NCLEX questions, pulled from our Simple Nursing question bank, written by actual NCLEX writers.
So question number 1, a patient with chronic kidney disease missed 3 dialysis sessions. With key terms here, potassium level of 8.1, wide QRS complexes, a heart rate of 58, and lethargy. Which order or prescription should the nurse implement first? So the key term here is high potassium with wide QRS complexes. That key term indicates dysrhythmias. So just think, you have to give calcium gluconate first to glue down those crazy heart muscles and prevent the progression into those deadly heart dysrhythmias. So option number 4, IV calcium gluconate, because the key term was about dysrhythmias and high potassium. Now, question number 2, end-stage renal disease with a potassium of 7.2, a BUN of 35, creatinine of 38, and urinary output of 300 mLs in 24 hours. Which order is priority? So this question says high potassium, right? But nothing about ECG dysrhythmias, or basically heart dysrhythmias. So we need to lower that potassium first with insulin, which puts sugar and potassium into the cell. So option number 1, IV regular insulin and 50% dextrose. Yes, we give this first. Not loop diuretics and not dialysis. This is used later. And definitely not option number 4, the vacation time, even though it's pretty tempting. Now, as far as nursing interventions, generally we check daily weights at the same time every single day. So the key number to know is 1 kilogram equals 1 liter of fluid retained. So we must report any type of fluid retention to the HCP immediately, because this can lead to fluid volume overload and hypertension crisis. Now, we also avoid the top drugs that can cause kidney injury, like NSAIDs as mentioned before. So just think N in NSAIDs is N for not good for the entire body. We also avoid milk of magnesia, that antacid, as well as antibiotics, those vancomycin and gentamicin. Remember, it's a sin to give a mycin since it kills the kidneys. As well as CT contrast dye. Remember, contrast kills those kidneys. Just think of that contrast dye like thick cement in those delicate washer machines of the kidneys. Now, as far as procedures, as mentioned before, hemodialysis, which is the machine version of the kidney, is used to wash the blood, but only used for a number of years until a kidney transplant is available. Now, we cover both of these in their own separate videos. Thanks for watching. Did you know you can unlock beautifully handcrafted study guides, packed with key points and memory tricks from all our videos? Plus, you'll get access to over 1,200 exclusive videos not on YouTube, all neatly organized by nursing school topic, to make that complex nursing knowledge actually stick. You'll also gain thousands of practice questions written by current professors and actual NCLEX writers. So for access to all this and more, click right up here or visit simplenursing.com. And don't forget to subscribe to our YouTube channel. Happy studying, and we'll see you in the next videos.